Hello, I'm Dr. Craig Childress. I'm a clinical psychologist in Pasadena, California. I work with children and families around issues of attention deficit hyperactivity disorder, angry, oppositional, defiant children, parent-child relationship problems, marital problems, things like that. In this video series, I've been discussing a particular type of parent-child relationship problem that I refer to as a parental alienation dynamic. And in this video segment, what I'd like to discuss is clinical competence issues related to the diagnosis, the Axis 1 diagnosis of the delusional disorder and the shared psychotic disorder. Now, the persecutory delusional disorder of the alienating parent and the shared psychotic disorder of the child that's shared through the enmeshed psychological relationship represent major Axis 1 disorders, and they fall under the category of psychotic disorders. And that sounds pretty severe. That's the same category that other diagnoses such as schizophrenia fall under. And it is. It's a pretty significant and severe category of diagnoses. The issue becomes, how did a clinician miss such a serious diagnosis? And here's my guess as to how that happened. First, child therapists are not particularly sensitized to working with a psychotic disorder. The psychotic disorders tend to show up as schizophrenia or schizoaffective disorder, and they show up in late adolescence, and they involve major mental disabilities. And so there's a different class of psychotherapists who work with that than the ones who work with children and parent-child relationship problems. What we see in child therapy is we tend to see angry oppositional kids, family problems, things like that. We don't tend to see psychotic disorders. And so there's just a lack of experience in child therapists of working with psychotic disorders. Now, from my own personal background, I worked for 15 years on a major UCLA research project regarding schizophrenia. And we would track schizophrenic patients from their first psychotic break for about 3 or 4 years, and so it was a longitudinal project. And through my association with that project, I was trained to clinical competence in a particular clinical interview scale called the Brief Psychiatric Rating Scale, BPRS. And that rating scale was about 18 items, as I recall, that 18 symptoms such as depression, anxiety, bizarre behavior, as well as the psychotic symptoms, unusual thought content, which is delusions, hallucinations, and conceptual disorganizations. And it was a 7-point scale, and anything rated 4 and above was considered psychotic on the psychotic scales. Anything below 4 was considered sort of normal range, maybe unusual, but still normal range. And what we would do on that rating scale is we would be making fine scale discriminations, such as on an unusual thought content, a delusion, the difference between a 4 and a 5. Okay, so a 4 is an encapsulated delusion that's just barely over threshold, whereas a 5 is more bizarre delusion. A 6, okay, now we have significant delusional processes that are flooding all over the place, and 7 is pretty severe. Similarly for hallucinations or conceptual disorganizations. So we're making fine scale discriminations between a 3 and a 4, or a 4 and a 5, and a 5 and a 6, and we're being trained to clinical competence in making these ratings. So I've been sensitized to what delusions look like at various scales. And this particular delusion, this persecutory delusion, I recognize it'd be kind of tough to identify. Okay, because it's not a bizarre delusion. It's what's called a non-bizarre delusion. Is it possible this other parent is inadequate and abusive? Oh, absolutely. That's within the realm of possibility. So it's a non-bizarre delusion. The definition of a delusion is a fixed false belief system that is non-responsive to contrary evidence. You can't change it. And it's fixed and it's false. And it doesn't respond to contrary evidence. That's a delusion. In this case, it's an encapsulated delusion. So it's a non-bizarre encapsulated delusion. What encapsulated means it's targeted around a very specific area. And when you get an encapsulated delusion, the person can look totally fine. They can go to work and they can talk to people and socialize at a party, and you'd never know they're delusional. But you hit that one specific area where they have the delusion, and all of a sudden you go, oh my goodness, that's really unusual. That's called an encapsulated delusion. And on the BPRS, we rated a 4. And so the persecutory delusion it's not bizarre, and so it's not calling attention to itself. In addition, the child's behavior within the alienation narrative confirms that delusion. Okay? That the child, in rejecting the targeted parent and yet being wonderful for the alienating parent, and likely being wonderful at school and wonderful in the session. They present as very hyper mature, very verbal, very well organized. So this is a wonderful kid. And yet the kid is really angry at this one parent. There must be a reason for it. And since they're not generally angry, it must have something to do with this one parent. Okay? And so the child's behavior confirms the delusional disorder of the persecutory inadequate target parent. That's its function of that child's behavior. It is part of the whole personality disorder process of the alienating parent. And so because the child's behavior confirms the presentation, and because it's an encapsulated delusion, because it's a non-bizarre delusion, and because the child therapist typically doesn't have much experience with psychotic disorders or recognizing delusions, they just simply miss the psychotic disorder. They simply miss the delusional disorder. Now, what should have happened, though, is that the splitting dynamic should have alerted the child therapist to look for a personality disorder, and in looking for the personality disorder, they should have recognized the borderline narcissistic and paranoid features. And when you get to the child and you begin to look at that behavior sequence of the child and realize that the child is not the victim of abuse, but the perpetrator of abuse, everything begins to fall apart. And as you look at the targeted parent and you do a behavioral analysis of what the interactions look like, and you realize that the targeted parent is totally normal range parenting, and yet you look over at the alienating parent and you have this presentation of a narcissistically organized inflation, and you have the splitting dynamic, and you have this sort of paranoid kind of malicious, malevolent intent, it all begins to come together. But because the therapist missed the splitting dynamic, because the therapist missed the personality disorder, they will then also miss the delusional disorder off of this. Now, I have a serious problem with that. Okay, while I can understand how the diagnosis was missed, it was nevertheless missed. That's a problem, because the problem is it hurts the child. It leaves the child in an enmeshed psychological relationship with a seriously disturbed parent who has a significant access 1 and access 2 psychiatric disturbance. That's going to harm the child. In addition, in missing those diagnoses, the therapist begins to collude with the pathological process of the alienation. And so not only hurts the child, but also hurts the targeted parent, who is the healthier parent and who is then deprived of a relationship with their child. And so while I can understand how the child therapist missed these diagnoses, the clinical diagnosis or the DSM diagnosis of the personality disorder or the psychotic disorder, I can understand how they missed it. That doesn't make it okay. People got hurt. And if you're going to do this work, you need to be competent in what you do. Now, it's okay for a lawyer to not recognize the psychotic disorder or the personality disorder. It's okay for a banker to miss it, or a stockbroker. It is not okay for a psychotherapist to miss it. That's our job. And so what it suggests to me is a level of professional incompetence. And in the next segment, I'm going to be discussing issues of professional risk management regarding that.